Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Marie Becker. Today's episode features Dr. Joyce O'Shaughnessy, Celebrating Women Chair in Breast Cancer Research at Baylor University Medical Center in Waco, Texas, Dr. Sara Hurvitz, Professor of Medicine and Senior Vice President of Clinical Research Division at Fred Hutchinson Cancer Center in Seattle, Washington, and Dr. Erica Mayer, Director of Breast Cancer Clinical Research at the Dana-Farber Cancer Institute in Boston, Massachusetts. They will be answering questions posed during a live program on CDK4/6 inhibitors in HR-positive, HER2-negative breast cancer that was held in June 2024. This episode is part of a larger educational program titled Cancer Conversations on the expanding therapeutic landscape for CDK4/6 inhibitors in HR-positive, HER2-negative breast cancer. For more information on the experts, along with a link to the complete program, including downloadable slide sets, an expert commentary, and an on-demand webcast covering the topics discussed in this podcast, please visit the show notes for this episode. Now, let's get started and hear what the experts had to say on these important topics.
I am Joyce O'Shaughnessy, breast medical oncologist in Dallas, Texas. My practice is Texas Oncology. I'm located at Baylor University Medical Center, and we do research through the Sara Research Institute. And I'm super pleased to be joined by two great clinicians, researchers, and teachers. Sara Hurvitz, who is Professor of Medicine, Head of Division of Hematology Oncology, Department of Medicine, University of Washington Medical School. She's Senior Vice President for the Clinical Research Division at the Fred Hutchinson Cancer Center as well. And then Erica Mayer, who is Director of Breast Cancer Clinical Research at the Dana-Farber Cancer Institute, Associate Professor of Medicine at the Harvard Medical School in Boston. I'd like to hand it over to Sara, who's going to discuss some of the data relevant to how do we ascertain risk.
So when we are looking at a patient in our clinic who has hormone receptor positive early stage breast cancer and trying to assess their risk, we use clinical factors such as the tumor size, which has been fairly well established as being prognostic, the nodal status, as well as the grade of the tumor. Higher grade tumor is associated with a higher risk of recurrence, and in many ways, these have been shown to improve the prognostic accuracy of gene expression signatures. We know that a higher proliferation, for example, Ki67, which is also associated with grade, and lower estrogen receptor levels do increase the risk of recurrence. And we know that failure of preoperative endocrine therapy to suppress Ki67 predicts poor outcome with adjuvant endocrine therapy based on studies now done over a decade ago. We know that tumors that are HER2 enriched or luminal B, which tend to be higher Ki67, loss of PR expression, are high risk early breast cancers, and endocrine therapy resistance is a key feature of high risk disease that's hormone receptor positive, recurring within 2 to 5 years of diagnosis.
We're on the threshold. We have one adjuvant CDK4/6 inhibitor approved. Initially, the Ki67 was a requirement in terms of getting that threshold 20% or above. That's no longer an issue. However, once ribociclib is approved in the adjuvant setting, in order for a T2N0 patient to go on who's grade 2, we're back to needing the Ki67. So I'd love to ask you, do you use the Ki67 now in your practice? Does it help you in any way if you do get it? What about you, Sara?
Well, in my former institution at UCLA, a Ki67 was reported out in all of our tumors. So I would take that into consideration, and usually it was concordant with the grade of the tumor. It was unusual for them to be different. This is such an unreliable immunohistochemical stain. The variability from lab to lab is wide. In fact, some data indicate that if it's anywhere from 10 to 30 or 40%, it's discordant, it's all over the place. So if it's really, really high, it's helpful. If it's in that intermediate zone, it's not helpful. And if it's less than 10%, that's helpful. I'll use it if I have it, but I'm not insisting on getting it now in my new institution where it's not standard to report it.
How about you, Erica?
So we're the flip side at Dana-Farber. We actually don't obtain Ki67 on any patients as part of standard of care for exactly the reasons that Sara mentioned. It's an unreliable test. There's a lot of intra-observer variability. And for that reason, it's just not performed. We can ask for it, But and as we'll talk about, there are other ways to meet criteria to get access to adjuvant CDK4/6 inhibitors.
So let's talk about how you ascertain risk. I guess the question is, who needs chemotherapy? That's one question. And then the thorny question of what chemotherapy in the HR positive, HER2 negative patients. So Erica, do you use the recurrence score for the most part?
Yes, we use chemotherapy. Recurrence score on the vast majority of our node-negative patients, both pre- and postmenopausal, and definitely in our postmenopausal node-positive patients. And we use it in select node-positive premenopausal patients. And I agree, we could talk about how we interpret that data all night long. But I do think it's important when we consider responder data in the premenopausal patients that when you really dissect the data, you can see that as patients are closer to their natural menopausal age, you can get benefit until the patient is postmenopausal, and then it completely evaporates. So it's really suggesting to us that what we might be seeing is the chemo effect on the ovaries, that this is an endocrine effect and not a cytotoxic effect. I do think it's a very valuable tool, and that's a key tool that we use in our practice to ascertain risk, in addition to very important clinical pathologic features such as size, node status, grade.
And once you decide a woman needs chemotherapy, do you have an algorithm where you would recommend a ACT-based regimen versus a TC-based regimen?
It's very interesting how across at least the United States and perhaps around the world, we all have slightly institutional specific ways of addressing adjuvant chemotherapy. Over the past 10 years, we at our institution have really worked hard to move away from anthracycline exposure when possible. Certainly there are situations where we are giving it in triple negative patients and in our high-risk node-positive, hormone receptor-positive, HER2-negative patients as supported by the ABC data. But in our node-negative, hormone receptor-positive patients where we want to give chemotherapy, a taxane-based approach like TC is very appropriate. And we really try to be very selective when we are picking anthracyclines for patients.
Thank you. And how about you, Sara, in terms of which of these genomic signatures, how do you use them? And also the adjuvant chemotherapy question.
I was very compelled by Mitch Dowsett's data, looking at the IHC4, single institution, centralized pathology review of ER, PR, HER2, and I believe grade of the tumor, or Ki-67. And it was very similar in terms of predicting what the oncotype recurrence score would be. So I try not to overutilize oncotype. If I see a patient who has very low grade, strongly positive HER2 negative tumor, I'm not going to order it on every patient. But I do think that those patients where you really are grappling with chemo or not, if it's going to change your decision making, I'll do it. And I still ask my patients before I order it, are you going to choose a different therapy? Even if I recommend chemo, will you take chemo based on the results of the score? That's important that we use these tests to inform decision making. So in the vast majority of situations, we're ordering them. In terms of the anthracycline question, I'm fairly famous or infamous, however, whichever side of the country you're on, for my stance on being very selective. And I love how Erica phrased that, like being very selective and thoughtful about our use of anthracyclines. Because to be quite honest, when you're in a clinic with a patient, the last thing you want to be accused of is undertreating a patient and feel responsible for their recurrence. And in many ways, we overtreat our patients with that fear of recurrence. The other side of it is the fear of a horrible life-threatening or life-altering complication of therapy, which I saw early in my career several times. So we are becoming smarter about how to utilize therapy. ABC finally reported its longer-term outcome this year. Those are very informative. 4 nodes positive or more in a healthy woman with ER-positive, HER2-negative breast cancer, standard of care is to offer them an anthracycline, 1 to 3 nodes. It's a nuanced discussion, in my opinion. Triple negative, a lot of us are doing neoadjuvant therapy, and we have the keynote data that's anthracycline-based. I've seen great results with docetaxel platinum, and I look forward to results with pembro. And HER2 positive, there is really no role for anthracyclines unless a woman is pregnant, and you can't give trastuzumab.
If you are going to choose to use anthracyclines, it is really helpful to have an oncocardiologist available who can see your patient. We do have data that there are cardioprotective medications like, beta blockers, ACE inhibitors that we know can help protect patients from long-term cardiac toxicity. So I find it very helpful to have that partnership available.
Absolutely. Completely agree with you.
That's great.
So talking about how we individualize therapy. When you have a patient who has early stage breast cancer that's hormone receptor positive that you deem is high risk for recurrence, assuming a patient is fit and you're considering adjuvant therapy, you have to consider how their risk is after doing chemotherapy. Looking at the differences in the NATALEE study and abemaciclib and monarchE study, and who would have qualified for each of these studies based on their anatomical stage of tumor. Neither studies would have enrolled a patient with stage 1A, but when you get into the T2, the stage 2A tumors that are node negative, these patients were allowed on the NATALEE study with node negative disease. And so there are a lot more patients that would have been eligible for the NATALEE study with node negative disease than with the abemaciclib study, which was restricted to node positive breast cancer. Both studies allowed both pre and postmenopausal women. If we have ribociclib approved in the near future and abemaciclib approved, all of us are going to have to look at factors such as access, financial impacts, risk of the patients, the long-term efficacy from the studies, as well as those inclusion criteria and how we apply the data based on the design of the clinical trial. And it's really important now that we have olaparib available that we all try to test as many patients as we can for germline genetic alterations, BRCA, even PALB2, I would say, to make sure that you have identified patients who would be eligible for treatment with that. So let's first consider the monarchE data evaluating abemaciclib in the adjuvant setting, 2 years of abemaciclib with endocrine therapy versus endocrine therapy alone. We have longer-term follow-up from this study that's now available. We're all relieved to see after that initial 24-month reporting that the IDFS curves continued to separate nicely. They didn't come back together. And the absolute difference at the 5-year mark was 7.6%. in favor of abemaciclib in, again, node-positive, higher-risk patients. The NATALEE data are less mature. A number of patients were still receiving therapy. Remember, patients received ribociclib for 3 years on this clinical trial. And again, it was lower-risk disease, so we expect the events to occur over time. The endpoint was met. It was met significantly. And the absolute IDFS benefit was 3.3% at 3 years, which is not really different from what we saw with the monarchE study. Neither of the studies have demonstrated a significant overall survival benefit yet.
Thank you so much, Sara. That's great. Here's a question. So would you recommend ribociclib in a post-man patient? She's T2N1, but her 21 gene recurrence score, her oncotype is less than 26. So do you have to have an elevated type to get ribociclib? What do you think, Erica?
This patient has node-positive disease, so she potentially could be eligible for either abemaciclib or ribociclib. And similar to what Sara said, I find the long-term follow-up data from monarchE very compelling. It's amazing how after 2 years of exposure, there's this carryover effect, and we just see a deepening benefit. And so that's very strong evidence that abemaciclib would be a preferred choice in a high-risk node-positive patient, assuming she otherwise met the entry criteria.
We don't know in the node-positive disease whether abema or ribo is the better agent. They differ in terms of tolerability, in terms of GI side effects and neutropenia potentially.
Just one question I want to ask Sara and Erica. Where, if ever, do you think about using preoperative CDK4/6 inhibitor and endocrine therapy in a patient whom you're going to be giving it to anyway, who qualifies for NATALEE or qualifies for the monarchE? What do you think, Sara?
So it's a reasonable option if a surgeon tells me the patient has locally advanced disease and I'm not going to be able to get good margins or the cosmetic outcome is going to be bad. Can you give something? I understand there won't be a pathologic complete response, but I need it to be shrunk. Then I think chemo or CDK4/6 inhibitor-based therapy with endocrine therapy is probably equivalent. Most of these patients are going to end up getting chemo as well. So then it's a discussion with the patient. Do you want to do chemo first or after surgery? I have no problem giving it before surgery. I just don't expect a path CR. In a lot of these situations, I'll use a recurrence score unless it's clearly locally advanced where I know that chemo is going to be useful.
Let's imagine an older patient postmenopausal with a grade 1 lobular locally advanced cancer. That's not a chemosensitive cancer. That's a wonderful opportunity to use preoperative endocrine therapy with or without CDK4/6. And an important thing is that patient's tumor is not going to respond in 3 months or 4 months. You need at minimum 6 months and maybe longer, as long as you're watching them closely. But the best therapy for that cancer, and one just needs to be patient with it.
Yeah, that's what I do. Do the same thing. There's another question here. In a patient with 4+ nodes, and she's germline BRCA2, you could give her abemaciclib or soon to be ribo, but she's also a candidate, of course, for olaparib. Do you give the 1 year of olaparib and give her 2 years of abema after the olaparib? What do you do?
Yes, that's what I do. We know from Olympia there is an overall survival advantage to receiving the 1 year of adjuvant olaparib. And I really want to support what Joyce said. We need to test all of our patients to know if they have a germline mutation for which we can be offering this. monarchE enrolled patients up to 16 months after surgery. So there is a pretty long window, and you can get the 1 year olaparib in, complete it, and then they would begin their 2 years of adjuvant abemaciclib. You have to explain to the patient we have a long road ahead of us, but these are all therapies with demonstrated benefit. And for a patient with multi-node positive disease, these are incredibly helpful tools.
I have done it twice, and the patients are exhausted after the olaparib. So it's tough. I've had to dose reduce the abemaciclib. It's hard to get it all in. I totally agree with sequencing the PARP inhibitor first.
When do we get germline BRCA testing? And NCCN supports germline panel testing for all patients, but particularly BRCA1, 2, and probably PALB2 as well, for all patients in the metastatic setting who are HER2 negative. So everybody in the metastatic setting who's HER2 negative, who's a potential candidate for a PARP inhibitor. In the adjuvant setting, there is basically anyone who's triple negative breast cancer, regardless of family history. And then there's a family history age. Everybody gets tested on 45, and then otherwise it's some family history. But quite honestly, testing everybody who's HER2 negative for sure, but even HER2 positive patient, I'm just, it's become so inexpensive. And we can do point of service testing. So I'm testing everybody these days.
Right.
Yeah, you do too?
That's what we're doing.
Yeah. It's just much easier.
Great. So now we're going to move on to talking about metastatic breast cancer, hormone receptor positive, HER2 negative. We have a few different decisions that we think about when we meet our patient with a new diagnosis of hormone receptor positive, HER2 negative metastatic disease. We have to think about, are they symptomatic or not? Are they in visceral crisis or not? Are they frail or have other comorbidities? Assuming that they meet neither of these criteria, and assuming they don't have a BRCA mutation, the vast majority of patients are going to go on to receive first-line endocrine therapy with a CDK4/6 inhibitor. These are the 5 first-line phase 3 trials, which established the role of our 3 major CDK4/6 inhibitors in the metastatic first-line setting. This includes palbociclib, ribociclib, and abemaciclib. The trials all had fairly similar design in that patients were randomized to an endocrine backbone alone or the endocrine therapy with the addition of the CDK4/6 inhibitor. For ribociclib, consistently across the MONALEESA trial cycle, there are positive overall survival results, statistically significant hazard ratios, and pretty consistently about 12 months or so improvement in overall survival for patients who received ribociclib versus those who did not. Just at San Antonio recently, we saw the final overall survival analysis from monarchE, which was the first-line abema study. This did not meet statistical significance, so technically that was negative. However, it's really important to look at the numbers here. There's a very similar, one might even say identical improvement in overall survival, about a 12-month improvement, very similar to what we see with ribociclib. That still makes abemaciclib competitive in this space when we're thinking about overall survival advantages.
Let's each say how we use our first-line therapy with our CDKs, how do we make the choice. What do you do, Sara?
It's pretty compelling that the ribociclib data was positive in terms of survival for all 3 randomized trials. So I share that with my patients. It's not right for everyone. There are patients who will have liver toxicity from ribociclib. We know Asian patients can have a lot of difficulty with ribociclib, and liver toxicity is not approved in Japan for that reason, for example. Abemaciclib has more GI toxicity, and I fully agree with Erica. The survival data are very compelling. That miss of the p-value was probably insignificant. So Both should be discussed with patients. I tend not to use palbociclib, the best tolerated agent, but probably not the most effective based on its potency.
How about you, Eric? What do you do?
Yeah, I have a very similar strategy. And, I think compelling is a great way to describe the data that we've seen in the past couple of years regarding ribociclib. But it's not the right drug for everybody. And, neutropenia is another side effect that we sometimes encounter. For that reason, abema might be a better choice. We saw data at San Antonio from the INAVO 120 study, which was 4 patients who had a PIK3CA mutation newly diagnosed using INAVO, palbo, and fulvestrant. And that was a positive trial. Perhaps that agent will become available to us. And really, palbociclib is the only CDK4/6 inhibitor that you can put into a triplet and have it be tolerable. And so there may be a continued role for that drug, but more in a combination setting.
Yeah, I tend to go, ribo is my number one go-to drug as well for the reasons stated. The only thing I would add is that I use abemaciclib when I feel like this cancer is highly unlikely to have any degree of endocrine therapy sensitivity to it. I feel that the data in the more severe disease, subsets, grade 3 disease, short treatment-free interval, lots of liver disease, support abemaciclib's efficacy, both in monarchE 2 and monarchE 3. So that's my go-to drug when I am looking at a cancer where I'm on the borderline of chemotherapy for. That's where I use abemaciclib. I still use some palbo too for patients where they have minimal disease burden and for whom quality of life is paramount, or other comorbidities. So I use all 3, basically.
What has become very interesting is what do we do post-progression? We now have really quite a broad spectrum of choices available to us following exposure to CDK4/6 inhibitor. Now more than ever, knowing tumor genomic profiling on our patients' cancer is really crucial so we can unlock the targeted therapies that might be available to them. We could certainly get that information from a baseline tumor biopsy, like the one you do to diagnose metastatic disease, but that may not pick up all mutations. If a patient is progressing, you definitely want to get ctDNA testing to know what's going on.
What do you think you would do if it's effective to switch from an AI ribopalbo to fulvestrant and abema as a second line, versus if you've got an ESR1, you got a PIK3CA?
If I had a patient come into clinic and post-monarchE was positive and she or he had been on palbociclib with an AI and had derived a good amount of benefit from it and now experienced progression and post-monarchE was positive, abema would make sense to be offered. Pretty well tolerated overall, manage the toxicity. But I do think that you need to also weigh whether or not use of something like everolimus would be a reasonable option. You have to have a balanced discussion about that.
How about you? What do you think?
Yeah, when we consider all of our endocrine and targeted therapy doublets that are available, they all come with a toxicity price. And if there's a PIK3CA mutation, if we're offering alpelisib or even pivasertib, there are risks of side effects that can have an impact on a patient's daily life. We have great comfort with CDK4/6 inhibitors. We can anticipate toxicity. We can manage it. We know how to make these drugs tolerable for patients. And so it's very compelling to be able to offer a regimen that is going to do well and be helpful for them and maintain and prolong their quality of life. We're going to start seeing patients, though, recurring on or soon after adjuvant CDK4/6 inhibitor. And we have to think about how we're going to manage those patients. That in some ways, it's almost like you're shifting into that second line setting for metastatic disease because you've basically already done the first line if the cancer's coming back while they're taking it. And so we have to begin thinking of a new paradigm for those patients. Thankfully, I really have seen little to none of that happening. Hopefully the adjuvant CDK4/6 inhibitors are working. But I do think we need to be thinking about our paradigms of how we manage the resistance that's going on in that setting.
Thank you very much, Dr. O'Shaughnessy, Dr. Hurvitz, and Dr. Mayer. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, Cancer Conversations on the Expanding Therapeutic Landscape for CD4/6 inhibitors in HR-positive, HER2-negative breast cancer, and to download the slide sets associated with this discussion from the Clinical Care Options website, click on the link in the slide notes. Thanks for listening.